Well, hey there, it's Liz Rohr from Real World NP, and you're watching NP Practice Made Simple, the weekly videos to help save you time, frustration, and help you learn more faster so you can take the best care of your patients. So today I want to talk to you about high potassium. Last week's video, if you didn't catch it, was about high calcium. I'm continuing on the lab interpretation series today. It's a little bit more complex than high calcium, but there are some simple frameworks you can use to think about high potassium, what it means, and what to do about it. So I'm going to again use another case study. So I was really hesitant to share this as a case study, but it's just so interesting. It's really hard not to. The reason I'm hesitant is because it's a little bit complicated and I don't want to overwhelm you or scare you. But things like this happen, especially if you're working in a setting where patients are a little lackadaisical about their healthcare. I'm going to keep this as brief and concise as possible. It is still going to be a little bit longer video than my other videos because there's a lot to learn, but I'm going to keep it as straightforward without the fluff so that you can absorb it, learn it, move on, be done with worrying about high potassium. So without further ado, I'm going to share my screen with you. So this is a great case from my first year, so let's hop into it. So this is George, again, not his real name or his photo. He's 63. He has diabetes. He's been a patient at this clinic for several years, but he was really lost to follow-up for about a year. So he's coming back to reestablish care. Again, first visit back from 1 year ago. He's intermittently taking NPH insulin 70/30, 20 units twice a day, and a sliding scale of Novolog, 5 units when he feels like it. He's not checking his blood sugars. He just takes it when he doesn't feel well. Luckily, he's a non-smoker. He drinks alcohol, a few beers here and there. That's on his first visit, what he would kind of admit to. And the more I got to know him, the more he was forthcoming about he was drinking a little bit more than that consistently. Past medical history, hypothyroidism. He has a remote history of CML, leukemia, chronic leukemia in remission. He also has high blood pressure. I believe he got a stem cell transplant from his brother in the past. I don't have full access to those records anymore, unfortunately. This is all kind of from memory. So he has no known past surgical history or family history. His blood pressure today is 150/90. He's taking Synthroid, 200 micrograms, aside from the insulin, and his other vital signs are normal, heart rate and oxygen. He lives alone, no sexual partners. He's on disability and he's not working. So our plan today, we're going to focus on hyperkalemia for the purpose of this video, but I'll touch on the other components of holistic care at the end. The labs we're going to check today are a CBC and a CMP. Those are for baseline liver kidney function, any anemia, signs of infection, signs of recurrence of CML, hemoglobin A1C for managing his diabetes, urine microalbumin, which is a yearly test for early signs of kidney impairment related to the standard of care for diabetes management. We're going to check his thyroid, TSH, and his cholesterol panel because of his age, high blood pressure, and diabetic status. So here are the results. Oh, they're kind of ugly. So before I get into these down here, just starting by saying the CBC is normal. His cholesterol is high, as we would expect. With the current diabetes, and his urine microalbumin is also high, so signs of kidney damage. But as you can see in the basic metabolic panel here, his creatinine is pretty high, 2.19. His GFR is pretty low, BUN is elevated. His glucose is super high, 572. His sodium is also low. I'm going to hold off on discussing that today. I'm going to make another video about low sodium. And his potassium, what we're talking about today, is 5.8. His chloride is also low. Carbon dioxide is normal. Calcium, protein, the liver function panels luckily are all normal. His TSH is luckily normal, so that's great. And his hemoglobin A1C is 10%, which does not really surprise based on the glucose level, but also the fact that he hasn't been here for a year and he's kind of not really taking his insulin as directed. So for hyperkalemia workup, I want to make this as simple as possible. There's a lot more causes than hypercalcemia if you listened and watched my last video. But I want to break it down and make it really easy. So these are the first kind of 3 steps. So number 1, is it truly high? So same thing as calcium. So this is a really important point I want to make. So kind of keep this in your mind. Potassium is normally stored in the cells. or it's excreted in the urine. Also stool, but mostly urine. So those are the main places you're going to find potassium in your body. And that's relevant because it helps you understand what the reasons are for high potassium in the first place. So we need to repeat this test with a basic metabolic panel or a heparinized potassium if available, because we need to make sure that it is not a false high or a artifact, which I'll talk to you about in a second. So just stick with me. So is it truly high? You're going to want to recheck it and verify it. And how high is it? And again, same thing as calcium. This is really a 1A and 1B, less than a step 1 and 2, because you need to think about it at the same time. So the normal range depends on your lab, of course, but my lab is 3.5 to 5.3. And first step here is greater than 6.5 with symptoms, they need to go to the ER, and or with symptoms, honestly. If it's 6.5 or above, I'm sending somebody to the ER, even if they have no symptoms, because the symptoms here are muscle weakness, paralysis, and cardiac conduction abnormalities. And so those are a little bit vague. And then when you see a patient, you're going to get the results like the next day. And you want to get that workup done quickly if they have a potassium of greater than 6.5. And so you're going to want to do an EKG right then. So they're going to have peaked T waves or a widened QRS complex, and that's kind of a simplified version, but those are kind of the first two signs you'll see on the EKG in terms of abnormalities. So is it truly high? How high is it? And then there are unfortunately not two diagnoses like high calcium, but two main categories of etiology. And understanding the categories really helps you figure out and remember, instead of rote memorization, where this is possibly coming from. So number one, increased release of potassium from cells. So remember how I said the majority of potassium in your body is inside of cells and excreted in urine. Number two is decreased excretion from the kidneys. So either there's more potassium getting into your bloodstream from the cells, or your kidneys aren't able to excrete it as they normally would. A quick note here I want to make is that it is extremely uncommon for an increased amount of potassium in your diet to cause an increased potassium if you have normal kidneys, because your kidneys are extraordinarily good at getting rid of potassium when they're healthy and will adapt to anything you eat in your diet to get rid of the appropriate amount. So unless you have kidney disease, abnormal kidneys, then dietary potassium is not a cause for hyperkalemia. So kind of bucket number one, increased potassium release from cells, so venipuncture and artifact. So unfortunately, when you use a tourniquet, when you pump your fist, when the blood components coagulate in your blood samples, then you can get higher potassium than is true. So that's one of the reasons why you want to recheck it. Hyperglycemia, hyperosmolality, lack of insulin. So when you have a lot of glucose in your bloodstream, it's going to increase the concentration, osmolality, and then the lack of insulin additionally is going to prevent you from getting the glucose into the cells. So when glucose is high and there's not enough insulin and glucose are the things that kind of open the door to your muscles and your liver to be able to absorb the glucose and the potassium. And so when you don't have that, that's going to increase the amount of potassium in your serum. So drugs, there's a whole list, so I'm going to hold off on those for 1 second. Other less common causes, but I just want you to know that this exists. Transiently can go up with exercise. It should improve over time with better conditioning, physical conditioning. GI bleed, typically like massive GI bleeds. Tumor lysis syndrome if somebody's undergoing chemoradiation therapy, but that's typically not seen in primary care. Burn accidents, blood transfusions, and this crazy diagnosis here, hyperkalemic periodic paralysis. For number one, this is outside of the scope of primary care because they should be seen in the ER, aside from exercise, of course. And hyperkalemic, this is something genetic. This is not that is a specialty diagnosis. So if you're getting there, then you've done your job as a PCP, and it's time to hand off to a specialty care. So decreased potassium excretion from kidneys. Number one, as you probably guessed, is kidney disease. So chronic kidney disease and end-stage renal disease. Drugs as well, but hold on for a second and we'll go through those. And then states of reduced blood flow to the kidneys. So if your kidneys are not getting sufficient blood flow to function the way that they're supposed to, they're not going to work as well. So they're not going to get rid of potassium as much as they should. So this happens in heart failure and cirrhosis, and which could also be on top of CKD, but those states in and of themselves can cause a reduced functioning of the kidneys. This is another kind of remote cause, hypoaldosteronism. This is a state that's typically caused by chronic kidney disease itself, as well as certain drugs, and I'm going to cover in 1 second. But it can be from adrenal insufficiency, a congenital cause, etc. But again, if you're getting to this stage and you've ruled out the CKD and the drugs, then this is time to seek care with a specialist. So here are the drugs. So I wanted to make a separate slide because there are just so many and they're so common. Beta blockers, not atenolol. So it's the beta 2. Beta 2 is what helps the potassium go into the cells. So if you have a beta blocker, it's going to block the potassium from getting into the cells, whereas atenolol is just the beta 1, the cardioselective one. So that's not an issue there. It's something to think about. Digoxin, not that common, but happens. NSAID, super crazy, but this can definitely cause a decreased filtering of the potassium. ACE inhibitors, ARBs, you've probably seen that before. Spironolactone, eplerenone, and triamterene. These are potassium-sparing diuretics, and not that common, but I figured I'd mention them because I see them fairly enough in primary care. I'm probably not going to say this right, but I've heard it pronounced multiple ways: tacrolimus. Anyway, however it's pronounced, these two kind of anti-rejection medications are sources. One that I forgot to write down that I just remembered, this always happens when I try to treat a UTI with Bactrim and somebody's on an ACE inhibitor. Bactrim can kind of also, I think it's the trimethoprim component of Bactrim, trimethoprim sulfamethoxazole, trimsulfa, can cause high potassium. I don't know if inherently it does or if it's just a combination of the two. But anyway, that's a common one. Heparin, not that common, but one to think about. So 2 steps to potassium management. So if you've gone through your 3 steps of how high is it truly high, how high is it, and thinking about these 2 kind of buckets of categories to work up, the 2 main steps to potassium management is number 1, is this safe to do outpatient or is it not? Do they need to be in the ER or can we work on it outpatient? And number 2 is identifying the causes. So the true treatment of hyperkalemia in the ER hospital setting, there's a whole algorithm for treating pure hyperkalemia. When you're doing outpatient management, you're really working on identifying the underlying cause and managing that, because you're not going to be doing things like giving insulin and D50 and giving albuterol and giving K-oxalate. You're not going to necessarily be doing, you really shouldn't be doing any of that stuff in primary care, and that's how they manage it in the hospital. So your job in primary care is to identify the underlying cause so that you can treat that in a safe way. And if it's not safe to do it that way, then they need to go in the ER. So those are your kind of 2 framing ideas. So this is an algorithm of the workup, and these kind of 4 boxes here, they really kind of need to be done around the same time in terms of thinking about it, but just stick with me for a second. So step 1, again, you're going to confirm hyperkalemia. If it's greater than 6.5 and they're symptomatic they need to go to the ER. So we've covered that. So if it's still greater than 5.5 and they're not symptomatic and you can go outpatient management. The first thing you're going to look at is the BUN and the creatinine and the GFR, looking at their renal function. So if you see high potassium, the first thing you need to think of, aside from like let's recheck it and make sure it's not an artifact, and it's not super high, is let's look at the kidney function, because impaired kidney is going to be the main reason you have high potassium. You also want to look at their glucose. So typically when you find hyperkalemia and you're not necessarily expecting it, you're just kind of doing screening labs for somebody, you're going to order a basic metabolic panel, and so you'll be able to see the glucose in the BUN, creatinine, GFR. So if somebody has impaired renal function, that's going to be number 1. Number 2 is going to be high glucose is going to cause that high potassium to be also hanging out in the bloodstream. So if this patient does have impaired renal function and they have ongoing potassium release causes, these are things that you're not really going to see in primary care. But if someone has an extensive burn or hypothermia or GI bleed or something that's causing active release from their cells of potassium, some kind of trauma or traumatic thing, you're definitely going to send them, even if it's not that 6.5, even if it's just above 5.5, because you don't want that to get worse and worse and worse. So the next thing, textbook says that if you have a high potassium, you want to do an EKG. So I'm going to say a real world note about that in just a second, but those are one of the signs and symptoms of high potassium, is the muscle weakness, paralysis, and then the cardiac conduction abnormalities. But just sit tight with that for 1 second. So you're also going to look at the med list. So to look at all those drugs. So let's kind of bring this together. So for him, it's safe to do an outpatient workup because his potassium is less than 6.5 on the first check. He has no symptoms. We don't have any EKG results, but just sit tight for 1 second. So these are his labs again. So this glucose is super high. His renal function, also not great. And his potassium is 5.8. But in terms of like the real world management of this patient, I'm kind of much more concerned about the glucose and the renal function right now than I am with the potassium. I'm definitely concerned about the potassium, but looking back to this algorithm, you're gonna, high glucose is gonna be one of those main causes that's gonna make the potassium be that high in the first place. So if we go back to the labs, sorry, 1 second. So if we go back to the labs, 572 on the glucose, when you lower this glucose, you're gonna lower this potassium. So, I mean that, we're not necessarily gonna change the creatinine unless this is an acute kidney injury. It's most likely gonna be chronic because he has the high blood sugar, out of control diabetes, he's also high blood pressure. I mean, topic for another time, but we can definitely talk about that. But in terms of management, you get these lab results, step 1. Step number 2 is you're gonna reconcile the meds with the patient. You're gonna give a call to the patient on the phone, say, hey, like, are you having any symptoms? Are you feeling okay? Just to confirm, these are the medications you're taking, correct? You're not taking a ton of NSAIDs. You're not taking any extra, medications that you forgot to tell me about. And then your step number 1, even before you recheck the potassium on that algorithm, you're going to want to lower the glucose and kind of fix the insulin situation first, because more than likely that's going to bring your potassium back down to normal in this case. So step number 3 is going to repeat the potassium. So over the phone, I advised him to recheck his blood sugar, to more consistently, I advised him of the danger of the situation, that, risk of death, if he wasn't, that this is a really serious situation that he really has to think about stepping up in terms of his management and if he's willing to do that or not. And if he's not, then he might not have to go to the ER, he might have to be hospitalized. So over the phone, he agreed to consistently take his dose of the NPH, consistently check his blood sugar. We decided on a sliding scale that he had used a year ago for his as needed with his meals, the Novolog 5 units, and kind of use that as he appropriately should instead of kind of willy-nilly. And then also working on decreasing his intake of those blood sugar raising foods and alcohol, things like that. After that, so this is moment 1. As soon as you get the lab results, I'm going to repeat the potassium either the next day or the day after that. Make sure that it's, see if it's still high or if it's come down at all with our glucose management. At that point, you can consider to do an EKG. So 5.8 is high, but you know what? Because he has all of these other reasons, so if he didn't have this and he just had the creatinine, I'd be a lot more concerned. So when he came back in for the potassium in 2 or 3 days, what you could do is you could do an EKG. You could do a visit with you to do an EKG and do a lab at the same time, or you could wait and see if his blood sugar went down, repeat the potassium in another day or 2, see if it went down, and if it didn't, then you could either pull him in for an EKG or do another visit. It's a lot of visits to do, but I think that the trade-off here is that you're risking somebody having to go to the hospital, be admitted, versus taking time out of his day to kind of come in. And his transportation was reliable enough, and he was also on disability, so his schedule was a little bit more flexible. He didn't have like a 9-to-5 job that he was trying to get time away from. And then the next thing after that, if his potassium went down, if it was trending on its way down, so I check it 2 days later, it's 5.6, I'll recheck it in another week. We'll keep working on the glucose, things like that. And then we'll kind of take it from there. So let's head back to George. So I was able to get his potassium down with his management of his glucose. He needs long-term diabetes management to get that A1C down from 10. And I can definitely make a video about diabetes management, but that's kind of a multi-pronged process here. So step 1, continuing his Synthroid. So his TSH was normal. So that's awesome. Continue with 200 micrograms. I'm going to work on lowering his blood pressure for his renal protection. Also, MI and stroke and things like that. I'm going to avoid ACE and ARBs right now because his potassium has been high, but I'm going to consider adding that back on because that is helpful for renal protection specifically, even though it raises potassium. I did a nephrology referral for him because, most likely his impaired kidney function is related to his high blood pressure and his diabetes, but there are other causes, and I'm not going to do those kind of fancy tests for a further workup for that. But I also don't want to leave that open and just kind of assume that that's the cause in case there's anything else going on with him. And also it's kind of further reinforcement in terms of like, hey, like let's take this really seriously because here's what dialysis means and you could head towards dialysis. And if we don't manage it, here's what's going to happen. And they can also be really helpful in terms of management of high blood pressure, in terms of making medication suggestions and giving me that reinforcement of feeling comfortable adding an ACE back on for him, even though we had a history of hyperkalemia in the past, because that is, like I said, really helpful for renal protection in particular. And then I did a follow-up with me. I did a couple of visits. I did the labs in 2 days and then a labs a week later. And then I had him come back for a visit with me in a month. And then you can either manage somebody like that every month. You have to kind of get buy-in from him, right? Because if he hasn't been there in a year and if you're telling him he needs to come in every week or every month and all that, like he might ghost you again, So it's kind of a discussion about, it's recommended, at least at my clinic, our protocol is that if your A1C is greater than 9, we recommend coming in once a month to kind of do further counseling and medication management, even if you're not necessarily checking the A1C every month that they're there. I definitely see endocrinologists who take over for me check every 3 months, and they are not necessarily seeing somebody every month because that's kind of like bread and butter for them. And for whatever reason, the A1C is not necessarily going to show any change within 3 months anyway, but that's kind of up to your discretion. So that's it. I'd love to hear from you. Is there anything from this video that is going to change your practice? Also, of course, anytime, please leave me a comment below if there's any topics in particular that you want to hear about, especially that came out of this case study. Did you like this video? If so, hit like and subscribe and share with your NP friends so together we can reach as many new grads as possible to make the first year as easy as we can make it. And don't forget to check out realworldnp.com and sign up for the email list. You'll get these videos straight to your inbox every week with little notes from me and some bonus content that I just don't share anywhere else. Hang in there. Thank you so much for watching, and I'll see you next time.